thank you so much for the introduction, and I'm really excited to be here talking to you all. I was based at Cambridge at HPS before moving to St. Louis to start my new postdoc, so I definitely miss Cambridge, even its rainy weather, and I'm really looking forward to being back for a little bit to talk to you all. I also just want to say that this is something that I've been thinking about, and this talk is very much kind of work in progress, and I'm really looking to start off a discussion here. So I hope that we'll have plenty of time to discuss some open-ended questions that I'll kind of raise at the end, and I'm really looking forward to hearing what you all have to say about the relationship between empathy and agency. And especially hearing what clinicians have to say if we have clinicians in the room. I'm also, a slight disclaimer, I'm not going to be talking about mental health in particular. I'm going to just mainly be talking about the kind of doctor-patient relationship and the therapeutic alliance. And this may apply to mental health in particular, but my aims are not just based in mental health care. Okay, so first, just to give you a sense of kind of where we're going in this talk, I'm going to tell you a little bit about what the empathy literature says about what is exactly the role of empathy in medicine and what are some kind of assumptions that people make about the importance of empathy. And I'm going to raise some kind of thorny issues that have come up in relation to the question of what exactly is the value of empathy in the clinical encounter. And then I'm going to try to shift the question a little bit, thinking a bit more about what empathy is actually for in the clinical encounter. And I think that this can help us think about questions about the relationship between empathy and agency and information in particular, and then provide some suggestion of where we might go moving forward with thinking about a better concept of empathy for the clinical encounter and for the therapeutic alliance. Well, let me switch slides. Okay, great. So a lot of people assume that empathy is really important within medicine, within the clinical encounter, in social work, in psychotherapy, and that in general, empathy is a really good thing for doctors to have. We have these kinds of statements being made all over the place. If we look at training manuals and guidelines coming from medical councils. So for example, the AAMC, the Association of American Medical Colleges, says that physicians must be compassionate and empathetic in caring for their patients. We see a similar kinds of language coming up in the Hippocratic Oath that many American medical students will read out at the very beginning of their medical training in their white coat ceremonies. We also have the Cambridge Calgary Guide to Medical Training, which is used often in the UK, which has this line that says, uses empathy to communicate understanding and appreciation of the client's feelings or situation, overtly acknowledges clients' views and feelings. So we have a lot of assumptions that empathy is something that doctors should cultivate, that it's really important in the clinical domain, and that doctors should be empathetic and caring towards their patients. We also see in this that empathy sometimes gets used interchangeably with compassion, or less so now with sympathy, but that there are a couple of other terms that people use to kind of capture this idea of being empathetic towards the patient. But there are a number of thorny questions that have arisen in relation to empathy. So one finding that came up that caused a huge splash and a lot of controversy was this finding that empathy decreases over the course of medical education. So if you measure doctors' empathy at the beginning of medical education and at the end, they seem to decline. And this caused a lot of worry about what's going on with empathy. And it kind of spurred on investigation into what empathy is and what exactly it's for. So there are three main issues that I want to point us to. The first one is about just conceptual difficulties that we encounter, not just within empathy in medicine, but within the kind of empathy literature more broadly construed in psychology and in neuroscience as well. So if we look at a review of the concept, this is one that came out fairly recently, we can see that there are many different definitions of empathy. There are lots of really different ways of conceptualizing it. And these authors came up with 43 discrete definitions. They mainly focused on the neuroscience and psychology literatures, but they also found some coming from the medical literature and from philosophy as well. And they argue that this inconsistent definition of empathy has a negative impact on research and practice because people have a really hard time communicating about what it is they're targeting when they research empathy. This problem that there are lots of different ways of thinking about and defining empathy has been widely acknowledged within the literature, and it's something that we can maybe talk a little bit more about in the discussion period if you're curious about the diversity of different definitions. But this kind of diversity of definitions also has an influence on the way that we measure empathy. So I mentioned earlier this problem that came up where people find that doctors decrease in empathy over the course of medical education. But of course, it depends what we mean by empathy and what kind of thing we're sort of looking for. So in one study, which was quite a helpful one, Radar Peterson points out that some of the measures that we use in medicine or that we have historically used in medicine to try to see whether doctors are empathetic are actually kind of just co-opted from other areas such as social psychology, and they may be completely inappropriate to the medical domain, or they may kind of conflict with the way that we think about what we mean when we say that doctors should be empathetic. So one measure that was used early on is this questionnaire measure of empathic tendency, which was developed by Mehrabian and Epstein, who are two social psychologists. They're mainly interested in measuring empathy and prosociality. And on this measure, you basically have these different items, and if it has a plus next to it, it means that if you respond positively to that, so if you say like, yes, that fits me, then you'll be rated as being more empathetic, and if you respond negatively to the other ones, then you'll be rated as being more empathetic on those ones, as on those items as well. So one item in particular says, I am able to remain calm, even though those around me worry. And this is a negatively rated measure. So if you say, yes, I am able to remain calm, even though those around me worry, you'll actually rate as lower on this empathy scale. Because this is supposed to be a measure of empathy as kind of emotional resonance with the other person. So if you say that you are able to remain calm, then you aren't really sharing their same emotions. But we can reflect on this and see that this is really in conflict with what we usually think about as being empathy in the medical domain. We want our doctors to be able to remain calm, even though people around them worry. And Peterson points out that this is a completely inappropriate measure for the medical domain, but because it's seen as a measure of empathy, it was often used unreflectively. And these kinds of problems of measurement difficulties and people having very different concepts of empathy mean that it's really hard to establish why we get findings like the finding that empathy declines over the course of medical education. If you're using this measure, then it may just be that people are getting to be better at managing their emotions, better at remaining calm, even though those around them worry. And that's a good thing, right? The finding that empathy declines isn't such a problem in this case. So we have these measurement and conceptual issues entering into a lot of the kind of difficulties around discussing what it is that empathy is good for in the medical encounter, and a lot of difficulties studying it. And then we have a lot of these findings being applied to broader conclusions about the value of empathy, not just within medicine, but more broadly. So there have been a number of really prominent authors arguing against empathy, both within the clinical encounter and more broadly. So one of them is this book by Paul Bloom, Against Empathy, where he argues that empathy actually leads us to be very biased towards some individuals rather than others. It spotlights individuals who are very kind of like prominent and compelling towards us. And empathy is subject to a lot of our cognitive biases. So this means that if we're thinking about its use within the medical encounter, it can't really support a fair distribution of healthcare resources. It's really bad for public health kinds of contexts. And it may also bias us towards thinking more positively about some of our patients than others. And so he argues that empathy is much worse than we think that it is across the board, and that we should really not try to cultivate our empathic tendencies because it's very subject to these kinds of biases. And then related to this kind of issue, we also have large questions about what exactly the value of empathy is. And these are related to some of the measurement and conceptualization issues that we encountered earlier as well. So when we look across the board to different studies about what empathy, how it's functioning within the clinical encounter, some studies seem to find that empathy seems to lead to burnout and distress among physicians. So there are a number of concepts that are used to kind of capture this idea. One of them is empathic distress. Another one is compassion fatigue, where people feel so overwhelmed by the emotion of the other individual that they actually can't help effectively. So they can't really figure out how to best help the patient. They just feel completely overwhelmed by their own emotions, and this can lead to burnout. Whereas other people seem to find that empathy leads to professional satisfaction and protects against burnout. And these are completely conflicting findings, right? We have the idea that on the one hand, empathy is really protective, and on the other hand, empathy is really damaging towards the clinician. And the question is, what exactly is going on here? And if you look more closely at these studies, a lot of the problem comes from the conceptual difficulties and the measurement difficulties. When people talk about empathy, it's really difficult to untangle what's going on because people have very different measures. They're thinking about empathy in very different kinds of ways. And so it becomes difficult across the board, basically, to talk about what exactly the value of empathy is. And we have a lot of difficulties of communication, both within different researchers, but also more kind of to the public more broadly. And there has been some kind of progress made. So people have recognized that there are these kind of conceptual difficulties and these measurement difficulties, and tried to come up with concepts and measures that are more tailored to the clinical domain. And part of this is a matter of making sure that those measures and those concepts are the ones that we prioritize. But I'm going to give you a couple of examples of them here. So two of the main people who have been working on empathy in the clinical domain are Jody Halpern and Jeremy Howick, and both of them have proposed much more kind of specific conceptualizations of empathy that are supposed to be for the clinic rather than really so much in contact with social psychology. So Jody Halpern has a definition of empathy in which it's a kind of, she calls it emotional reasoning. So within the literature on empathy, I said that there are lots of different concepts, but one of the main ways that people divide up the field is between empathy as being cognitive. So empathy is being about understanding the perspective of other individuals, and empathy as being emotional. So empathy is kind of feeling with other individuals. So just kind of resonating with them and feeling what they're feeling. Jody Halpern's definition here has a little bit of both elements, but it's sort of more on the reasoning side, right? It's focused on attuned, curious listening, facilitating the information exchange and information gathering aspect. But in Halpern's view, you use your emotions to kind of help you guide what sorts of questions you might ask and guide this attuned, curious listening process. So it's not completely devoid of the emotional aspect, but it involves this kind of curiosity, suspension of judgment, assumption that you actually don't know what the other person is thinking or feeling, and that you need to go out and find what they're thinking and feeling. This is quite different from other ways, even everyday ways of thinking about empathy, where we often think that if we empathize with someone, we automatically gain an understanding of them. This definition is quite far away from that, actually. It involves a kind of humility. And Howick's definition of therapeutic empathy is somewhat similar to Halpern's in that it focuses kind of on the understanding and the communication aspects of empathy here. So Howick says that there are three elements to therapeutic empathy. One is understanding what the disease means to a patient. Two, communicating that understanding. And three, acting on that shared understanding in a helpful or therapeutic way. So Howick, as we can see here, doesn't even really mention the emotional aspect of the empathetic exchange. It's much more focused on the kind of informational value of empathy here, or the epistemic value of empathy. And similarly, we have measures of empathy that have been developed for clinical practice in particular. So one that is particularly popular in the kind of interaction between doctors and patients is the care measure. And if we look at this, I've given you an example from the care measure for pediatric context and an example from the care measure for adult populations. And we can see again that it's much more focused on the kind of informational and the epistemic elements of empathy, right? So if we look at the pediatric ones, we do have the idea of feeling happy and relaxed and kind of the idea of being friendly and caring, but we also have a big focus on asking questions, letting you talk, listening, understanding. And then if we look at the adult one, we have the idea of letting you tell your story, really listening. We have showing care and compassion there too, but we have explaining things clearly, helping you to take control. And so this is supposed to be something that is really facilitating the epistemic or the informational aspect of empathy. So these kinds of measures are much more focused for the clinical domain, and we can see that they're really being driven by a focus on what it is that's needed in the clinical encounter. And then we have had some help from neuroscientists who have kind of been able to tease apart some of the different processes and the ways that the different concepts of empathy might be pulling on different neural processes. And I'm not going to go into a lot of detail about that, but it can be helpful for untangling some of the different background issues that are going on. And so basically what I want to kind of sum up on is that thinking about these conceptual issues and thinking about how we might use empathy in the clinical domain, instead of asking just what empathy is, we should be thinking more along the lines of what exactly is it for, and how do our measures and our conceptualizations support the aims that we might be going for when we're thinking about the relation between doctor and patient in the clinical encounter. And this is basically just summing up what I've kind of articulated based upon the measures that come from the more clinical literature, the kind of more tailored measures and the tailored concepts of empathy. But the aims are about shared understanding, communication, decision-making, promoting patient autonomy. That's something that Halpern says explicitly in her book, and supporting the doctor-patient relationship and the therapeutic alliance. So here, again, we just have this focus, this highly focused element of the epistemic and the informational value of empathy. And that's quite far apart from some of the social psychological ideas about emotion sharing. And the emotional aspect of it is secondary. So this can help us to see what exactly empathy is supposed to be doing in the doctor-patient relationship. And then we can think a little bit more about how exactly empathy might support these different aims. In particular, for this group that's interested in agency and autonomy, I want to think about how this kind of empathic, open, attuned, curious listening, if that's what it is, might promote patient autonomy. And how it might fit in with these findings about burnout and distress in clinicians, and how it might mediate against those things. And so what I'm going to say in the rest of the talk is just quite speculative and kind of opens up questions for us to discuss. But one thing to notice that I think is quite important is about the directionality of empathy and the way that we talk about it. Even in some of these more recent discussions of clinical or therapeutic empathy, we often think about the direction of empathy as going from clinician to patient. So it's the responsibility of the clinician in most of these conceptualizations to be empathetic towards the patient. And it's a kind of one directional sort of thing. You don't usually have a more relational idea of empathy, where you do have ideas about shared understanding kind of coming in, but it's unclear how exactly you're attaining that element of shared understanding. It's still, the rhetoric is largely around that the clinician has empathy for the patient and that they're supposed to be the ones who have the burden of understanding where the patient is coming from. And this places a lot of responsibility on physicians. And it, even though empathy seems to fit into, so there's this classic paper on 4 models of the physician-patient relationship. And empathy seems like it should fit within an interpretive or a deliberative model, which is where you have a kind of built therapeutic alliance and the clinician is helping the patient to figure out what their values are, and there's this shared decision-making process. I think that in effect, a lot of the rhetoric around empathy, and part of the reason why empathy can be quite stressful for clinicians, is that it's still fitting a bit more into an informative model where the clinician is tasked with understanding what kind of information they need to impart to the patient, and it still has this kind of one-way transmission sort of implication. And when a lot of these therapeutic and clinical empathy views were coming out, a lot of responses to them were quite skeptical, in particular on the problem of time and how we can make this very involved form of empathy fit into what is an extremely taxed and very time poor and resource poor healthcare system, where clinicians don't have time to engage in these long, detailed conversations with their patients. So this is one of the main critiques that kind of came up. One quote from Philip Perry says, "This model of empathy depends on time and on a limitless store of altruism. These obstructions to empathy are explored too swiftly." And so here, just again, pointing out the kind of stressful nature of having this one-way direction of empathy, and fitting in with autonomy, the model still seems to be one where the patient is the primary or the sole decision maker, and the clinician is kind of responsible for anticipating what questions or what information they need. So it's placing a lot of responsibility on the clinician, and the demands may actually be quite high. So moving forward, I think that one thing that we can try to think about is how to create a more relational way of thinking about empathy and autonomy, thinking more about the reciprocity between clinician and patient, and in developing this therapeutic alliance as a kind of like genuine alliance. And I'm not sure what the answer to this is or how exactly we can do that. It will definitely involve kind of cultural and structural shifts, but I wanted to bring this into contact with some of the things that feminist scholars have said about relational autonomy, where there the idea is that we can try to structure the clinical visit differently to embed a different kind of expectations about what the patient's role is and what the doctor's role is. And I'm really curious to hear what you think about how exactly we might make this work, especially in our very demanding healthcare environments. But trying to bring a more relational idea of empathy into contact with a more relational idea of autonomy as well, and not making it so that the burden is just placed solely on the clinician as empathizer. So I'm looking forward to hearing your thoughts on this. Thank you.
Thank you so much. We definitely can. So if Caroline is recording, so we're all good.
Okay, excellent. So I'm going to be talking to you about cognitive behavioral therapy as it pertains to client agency. And the talk is based on a recent book chapter I did. So it's going to come out in the OUP Handbook for Psychotherapy Ethics, which I co-authored with Christopher Pope, which unfortunately he's not here. So basically what happened was I wrote the cognitive bit and he wrote the behavioral bit. So if you came to hear about the behavioral bit of CBT, I'm very sorry, you're going to be disappointed because I'm just going to talk to you about the cognitive part. So what I'm going to say is a little bit like this. So here's a brief rundown. I'm going to introduce you to the idea of agency as it features in the ethics of psychotherapy. And then I'm going to introduce just enough cognitive behavioral therapy that you can see the bits where agency becomes a problem in CBT. And for those of you who are not familiar with CBT, it's probably, I don't want to overstate it, but it's probably the most prevalent school of contemporary psychotherapy. So for instance, in the UK, if you go to the NHS, you're most likely going to get CBT. So if you go, especially for depression and anxiety, it's considered the treatment of choice. So it is everywhere at the moment, particularly I think in sort of Anglophone Western countries. So this is how largely I ended up working on CBT. Oh, and I should say there is a link at the very end of this talk to the book chapter if you want to read more about the thing, because we do end up talking about other ethical problems posed by CBT there. Okay, so the professional ethics of psychotherapy are actually really interesting because unlike psychiatry or being a medical practitioner, you don't kind of get licensed in an obvious space. So what ends up happening is that there is a long list of different kinds of guidelines that may apply to you depending on what sorts of professional associations you choose to join or which geographical region you're in, right? So, and each of them, interestingly, talk about agency in slightly different ways. So sometimes it's discussed just directly. Often it's described in terms of autonomy and self-determination, which is the way it's conceptualized in medical ethics usually. And then you get discussions of what I take to be agency in terms of dignity or respect for client boundaries. And also just more generally in the secondary literature, what you get is an interest in agency where the client is understood as a consumer, right? So someone who's authoritative and an expert on their own lives, and they're coming to seek a product, right? Or a particular kind of intervention that they think will be useful to them. So I'm going to pick up on that last one eventually, because I think it does present particular challenges for therapy and CBT in particular. Okay. So based on all of the various guidelines, I sort of ended up with this working definition of agency as it pertains to psychotherapy. So it's an understanding of the client as an agency with their own beliefs, values, and boundaries that need to be respected and, where possible, supported and enhanced. I should say, for those of you who are weirdly obsessed with ethics guidelines like I am, I have an entire folder where I collect them. Agency tends to feature in ethics guidelines and codes in the parts that are often referred to as non-enforceable. So they're not the sort of thing that you can take a clinician to, their licensing body or their professional organization as failing to meet. So they're often found in the principles and values section. So they describe best practice rather than a minimal standard that you must meet. So I think it's a really interesting insight into what a good account of therapy looks like. And like the notion of agency gives you very interesting into that. Okay, so cognitive behavioral therapy. So the central concept that cognitive behavioral therapy brings to the understanding of mental illness is the cognitive model of mental illness. So the cognitive model claims that the negative emotions and behavior that are symptomatic of mental illness stem from distorted patterns of thought. And these distorted patterns of thought are often described as cognitive distortions, thought distortions, or negative automatic thoughts. And on the left, you should see what, if you have any familiarity with CBT, you'll have seen this before. This is the cognitive triangle. So thoughts influence emotions and behavior. And because the cognitive model takes thoughts as quite fundamental, a lot of CBT focuses on intervention on thoughts. Okay, so here's an example of how the cognitive model might work. So this is a really common scenario you find in CBT training manuals, by the way. So a student performs kind of mediocrely on a test, and then they believe that they have in effect failed the entire semester, right? So, oh no, I did terribly, I'm going to keep doing terribly and I'll fail the entire degree. So here's a couple of distortions that might arise around this scenario. So I failed that test, so I'll end up failing the rest of the course, counts as a cognitive distortion. The classification usually would be something like overgeneralization or catastrophizing. So because you sort of, infer from this one failed result that everything will go terribly wrong, right? Or here's another one, it's I should have studied harder, or something like I should have been a better student, I really should have done more. So this counts also as a cognitive distortion. Okay. So CBT's main therapeutic method is to teach clients to identify, evaluate, and replace these distorted thoughts. So here's one way this might work. So if the student wasn't convinced they'd fail the course, then they'd just start doing productive things like studying, they'd feel less terrible, that sort of thing, right? Okay, so the question of cognitive distortions and all these distorted thoughts that underlie the cognitive model of mental illness invites the question, so what exactly is distorted or wrong about these thoughts? And this is usually classified in a variety of ways. So you get told that there's issues of validity and utility with these thoughts. You get told they're faulty and unhelpful, or inaccurate and maladaptive. So in the rest of the talk, what I'm going to do is look at validity and utility and tell you each of the distinct challenges they pose for an understanding of agency. Okay. So just to clarify, validity refers to epistemic failures. So it might be that you hold an inaccurate or false belief, you've made an unwarranted inference. So for example, the student who thinks they failed the entire course based on one test, you'd think there's a failure of validity there because it's an unwarranted inference based on a very limited pool of data, right? And utility concerns issues relating to negative emotions and unhelpful behavior. So a thought like, oh no, I'm going to fail the entire course because I did badly on this test, it's distorted by virtue of entailing those negative emotions and behavior, okay? Cool. So validity, validity as it gets evaluated in cognitive behavioral therapy is where the clinician will encourage you to identify the epistemic issues that may arise. So often you'll get a dialogue where the clinician will ask you to think, oh, is that plausible given what's happened? Is that the best explanation for this current situation, and so on? And I think this approach, the focus on validity, presents particular dangers. So for instance, there's the danger that it might make the client feel like their thoughts are irrational or pathological. So this is obviously very distressing. But what's really interesting about this is that for the purposes of agency is that it presents a situation where it looks like the agency and especially the authority of the client is being challenged, right? So you're being told your perception of this event is wrong. And this sits very badly with that idea of the client as authoritative with regard to their own life, right? So, third wave CBT actually notes this difficulty, and it tends to focus more on issues of utility, so direct worries about, hey, how does that thought make you feel, rather than is that thought implausible? So it's not epistemic, but rather concerned with the repercussions of thoughts. And it tends to adopt more sensitive language that don't entail the same ideas of irrationality and deviance as distorted thoughts. So you get a school of dialectical behavior therapy that focuses on stuck thoughts rather than distorted. And the language of negative automatic thoughts is becoming more common as well, right? Okay. So Utility also, much like validity, presents particular challenges for agency, and they come up in a whole different set of therapeutic techniques. So utility comes up when you do cost-benefit analyses of cognition. So you ask the client things like, okay, so you believe that you're going to fail based on one particular test result. How does that make you feel? Does it make you more or less likely to keep studying? Do you think that's a good idea? So you're drawing attention to the negative behavior and feelings that follow from the thought here and asking you to think, well, what are the costs of holding that belief, right? And the distortion that comes up a lot in utility is the one that I raised earlier about the shoulds. So things like, I should be a good student, I should have studied more, or here's some other ones using normative language, I should be a good daughter, people ought not lie. What should be really apparent with the shoulds, and I'm highlighting it in particular, is that the sort of language that picks up the shoulds, so normative language, should, ought, must, is also the language of our value systems, right? So the shoulds can encompass everything from just very low level things like I should have studied more, or I should have been a good student, to your religious values. So something like people ought not lie would fall under a broader religious or ethical framework. And it kind of describes our deeply held beliefs about how people ought to act, right? And even something like I should be a good student. So this could be just sort of a low level thing you've started to think, or it could be an expression of one of your deep life projects. So by value laden here, I mean something like it's really important to you in some way, right? Either in your ethical conception or just in terms of your vision for a good life. And utility bears down on this quite substantially, particularly with regard to that specific distortion of the shoulds. Okay. So utility, when it works well, evaluations of them can bring up a whole bunch of quite interesting cases. So where your values seem to entail negative utility. So you might think, oh, I have to be a good daughter, but all that thought is doing is making you miserable, right? And the student who's done quite poorly on the test might keep thinking, oh God, I should have studied more, I should have studied more. And it's not actually helping them study more, it's just making them miserable. There's other cases where these values have been adopted unquestioningly. So you might think, actually, how have I come to believe that I have to be a good student? Is it that I've spent all this time in academia and I haven't escaped, right? So upon reflection, doing things like cost-benefit analyses and things where you go, oh, actually, all this thought is doing is making me miserable, should ideally highlight that, A, it's not a fruitful thought to have, but also, hey, how have I come to have this unfruitful thought? And finally, and this is the case where I'm very interested in, so it can raise situations where the client seems to be acting against other values they have, right? Or just acting against their values in general. So you might think, for instance, if you're constantly stressing about being a good daughter, it might make you actually a little bit snappy with your parents, right? You try too hard. And then when you get around to interacting with them, it just doesn't go very well because you're trying too hard. This is definitely a little close to home, and I'm starting to realize I should call my parents more often as I'm doing this. But where this presents a really deep challenge to agency evaluations of utility is instances where you get these kinds of trade-offs and the client is willing to incur various costs. So there's costs where you're quite happy to take up the negative utility. So you think it's fine that you feel a little bit guilty about not being a good daughter because it spurs you on to be a better daughter, right? Or where there's cases where you have this tension. So you think, okay, I need to be a good daughter, but that seems to be going poorly with this other belief that I have about being a good student because all I do is talk to my parents on the weekend. And at this point, you have to make certain kinds of trade-offs to preserve a more central value, right? So CBT tends not to, as it's kind of described in standard training manuals, to not pick up on these various tensions. And I think here there is a danger of challenging the client's agency and their values and not taking them sufficiently seriously. So either by not acknowledging that we're quite happy to incur certain kinds of trade-offs for our values, or where you have to just acknowledge, okay, there are these various tensions. Often what tends to happen in sample dialogues, at least in training manuals, is that there's a very obvious central value, and the tensions are often not highlighted, right? So I think what we highlight in this chapter is this need for a certain kind of nuance, where clinicians are encouraged to recognize that there's trade-offs, possible tensions, and even cases where clients will just go, this makes me unhappy, it seems to sit very badly with a whole lot of other values that I have, but I'm quite happy to preserve this central value. There's not a problem to be solved here using these tools. Okay, so I think, because I did a very short talk, and I didn't actually, as I recall, propose any solutions. And conveniently, Riana has highlighted the sort of solutions that we do propose in the book chapter, which is very much that it matters how you talk to people about these things. So in the chapter, we discuss this in terms of the therapeutic alliance in particular, that it matters when highlighting that someone has a thought with epistemic issues, for instance, that needs to be handled quite sensitively, right? And part of the shift that you get in more contemporary CBT towards less, I want to say, judgmental language, so stuck thoughts, negative automatic thoughts, rather than distortions, that seems to be a good shift towards that kind of empathy and sensitivity around at least evaluations of validity. With regard to utility, we kind of call similarly for a greater nuance and sensitivity. So not just kind of assuming that there's straightforward solutions to these problems, and especially acknowledging trade-offs, that there just might be values that clients will want to hang on to. So distortions expressed in terms of shoulds that they actually want to hang on to, despite the fact that it makes them miserable, it sits badly with quite a lot of other values, right? So that basically, I think the thought is that the situation is quite complex with both evaluations of validity and utility, and it matters that you handle this very carefully to preserve the client's agency and the therapeutic alliance. So this is my email address, and this is my academia page where you can find a preprint of the paper